Rachel, just let me know when you're ready.
Go ahead. Sorry.
Okay, great. Well, hi, everyone. We were just going to present a little bit about opioid use and opioid use disorder in pregnancy. And then Dr. Claire Smith is going to present a case for us related to this topic. I want to just start with the current state of drug overdose in pregnant and postpartum women. We talk about drug overdose and drug overdose deaths really as a proxy for substance use disorders. And so although I'm talking about overdose, we're also talking about a vulnerable population that likely has an underlying substance use or substance use disorder. We want to talk about an approach to reducing drug overdose deaths and the treatment of opioid use disorder. So as many as you know, looking at our maternal mortality data in our country, mental health conditions are the leading cause of maternal mortality, and that is by suicide and drug overdose. And we've been watching this trend for a number of years now. From 2010 to 2019, we're just seeing this sort of constant uptick in drug overdose deaths for maternal deaths. As you can see there, that percent increase has been about 190% over 2010 to 2019 in terms of drug overdose deaths. And what we should realize is that this is really just mirroring what's happening in the general population with the opioid epidemic. And we, of course, we would see this among pregnant and postpartum people as well. These are just some recent numbers, just giving you estimates of the drug overdose maternal mortality rate in comparison to drug overdoses in reproductive age women. And what you see, it's about 8.3 per 100,000 deliveries in maternal drug overdoses and deaths, and about 15.7 in women of reproductive age. What's important to recognize with these data is that this is sort of preceding the opioid epidemic, the pandemic, the actual COVID-19 pandemic. What I just want to highlight here is that these data kind of give us a sense of what is driving these overdose deaths and when. It's primarily our basically completely synthetic or semi-synthetic opioids, which are things like fentanyl. So fentanyl is the major driver of these deaths. Next in line are psychostimulants, and often those two together are really what's resulting in these outcomes. It's also important to recognize that when these outcomes are occurring, they're typically late postpartum year. So oftentimes after women have made it through pregnancy or the early postpartum period, it's that late postpartum period that they're really at increased risk. I wanted to put these data in here because they just came out last month, and they really give us a sense of what has actually transpired during the COVID-19 pandemic, which is really concerning. The data that I just presented you before, when we compare overdose deaths in pregnant women to women of reproductive age that are not pregnant, we typically always see that women of reproductive age but not pregnant are more likely to overdose on these drugs in comparison to pregnant women. Pregnant women has always been sort of like this protective effect in reducing drug use and drug overdose deaths. We do not see this during the COVID-19 pandemic. We're actually seeing rates of overdose deaths among pregnant women to be similar to non-pregnant women, women of reproductive age. So in the COVID-19 pandemic, we've really had a very significant surge and spike in these deaths, and that's what we're seeing in our maternal mortality numbers. In terms of race, just sort of across the board, these numbers look very similar, whether you're pregnant or not pregnant, except for non-Hispanic, American Indian, or Alaskan Native populations, and having even higher rates than non-pregnant populations, which is pretty concerning. Again, these data just give us a landscape and help us understand who's our most vulnerable population in this. With these data, if you were a younger age, if you were a non-college graduate, if you were unmarried, you are more likely that sort of increased your risk for overdose death in comparison to these other groups. And then also, as I alluded to before, these deaths are occurring late in the postpartum year and often in women's homes. So as opposed to where we're used to most of our maternal mortality, if it's in pregnancy or early postpartum, being the hospital. So as we approach and try to tackle our national problem of maternal mortality, we all recognize that this is a really complex problem, and it is mostly multifaceted. There are multiple contributors to that. And I like to organize things according to the ecological system theory, because it helps us really just think about the different levels and the different targets that we should be thinking about, and recognizing that it's not just one of these targets, because all of these things have sort of a confluence and effect together in producing these outcomes. So as we're designing interventions, we're really thinking about targeting the community, targeting interpersonal, targeting individual, and also societal. And as this applies to substance use, what we really need to be thinking about is that on the societal level, our structural targets have to do with our policies and our laws. And so, we are practicing in a state where we have social and legal consequences as a result of substance use and pregnancy that can result in loss of custody of children. Women can end up in prison. And those things alone are deterring women, not only from just admitting that they are having this problem and reaching out for care, but it's actually a deterrent to just prenatal care. And we know that if you have a substance use disorder and you get prenatal care, but not substance use treatment, you're going to do better than somebody that doesn't get prenatal care. So this is just an area that needs to be on everyone's radar, and advocacy around changing these laws and these policies so that women will at least be able to get prenatal care without fear of social and legal consequences. On the community level, we know that in mental health and in substance use in general, there's often very low access to available or accessible treatment. This just gets heightened in pregnancy and the postpartum period. There's some interesting studies where you create these like secret shoppers. So people reach out to try to get buprenorphine or methadone treatment and say that they're pregnant. And if you say that you're pregnant, you are significantly less likely to be offered an appointment in comparison if you are not pregnant. So in addition to all the barriers that we have to substance use treatment, it's particularly difficult if you're a pregnant person, and also if you're insured by Medicaid or other public insurances. So on the interpersonal level, we know that there's a lot of biases that come about. There's a lot of stigma and discrimination towards substance use, but particularly if you are a pregnant person. We know that providers often don't have a lot of education on this topic or how to address it. And so that's another major area of intervention. And then on the individual level, we know that social terms of health certainly complicate the picture of any disease, but particularly around substance use disorders. And that sort of kind of intersects with other complications to increase the risk of complications. So one of our programs that we are is a statewide program. This is a perinatal psychiatry access program. We call it Mom's Impact. And essentially any frontline provider. So if you are working with a pregnant or postpartum woman, probably anybody on this call that is seeing someone with mental health, but also substance use, in particular opioid use, you can literally pick up the phone and call us, and we will help walk you through the next steps of management of this patient, including starting buprenorphine for opioid use disorder, if that makes sense. This is also a program where you could reach out to and refer patients for treatment. The way this works, again, what we're targeting here is sort of the community and interpersonal levels so that we are building provider capacity to feel more comfortable identifying and treating these conditions. So if you're in a practice and you want additional trainings for your practice to better identify and treat these conditions, we're available to do that. And as I mentioned, we're available as a provider-provider consultation. And that's just a quick flyer on that. The other thing that you are able to do is you can refer patients. You can have patients refer themselves to this program, where they would reach out, they would talk to a care coordinator who would assess what their needs are and get them access to treatment. And that is sort of the flyer for that. We're happy to share that. But I just want to quickly dive into treatment of opioid use disorder. What's really important about this is to recognize that this is not just about medications. It's also what we want to see happening is that there's therapy, there mental health and traumas being addressed, social determinants of health, and we're doing that in a coordinated way with OB. Medication is a really important component of this treatment. We know this is these medications have been demonstrated to be essentially life-saving. They reduce overdose deaths, they improve functioning, they reduce transmission of infectious diseases, they reduce criminal behavior. It's pretty incredible how effective these medications are. We just want people to use them. And the way that we use them in pregnancy is often a big part that needs to happen, and is sort of all of our responsibility is around education about the use of these medications for women. So what we talk about is sort of the risks of medications for opioid use disorder. And then we also talk about what are the risks of not being on these medications. And there are risks with these medications. A lot of people don't want to be on them. A lot of people have difficulty with travel and cost. There is an increased risk of prematurity, low birth weight, and NAS with these medications. And some of the most recent data, which I think is really helpful, gives us a really good sense of what are the actual risks of these outcomes with these medications. I'm going to share with you guys after this sort of a guide that gives you all of these numbers. So if you ever were to sit down with a patient, you would have this in front of you where you could sort of explain the risks of some of these medications. So looking at risk of NAS, buprenorphine, it's about 50%. With methadone, it's about 70%. Preterm birth risk with buprenorphine is about 14% versus methadone, 24%. And you guys can look at these numbers. I think what's probably the most important thing about this work is it just sort of gives you an ability to provide education to the patient so that they understand this is the percent of people that are on these medications where they would have this outcome. This information, though, should not guide whether you decide to choose methadone or buprenorphine for this patient. What you want to do in choosing a medication for the treatment of opioid use disorder is choose the one that is going to work the best for that mom. And that's the one that's accessible, it's available, and it's going to reduce her risk of relapse. You do not want to switch. So as I kind of showed you, methadone has sort of these higher rates of NAS and preterm birth, and that sort of concerns people. But what that data doesn't show us is that if we switched from methadone to buprenorphine, that would, number one, lower that risk. We have no idea if that's actually the case. And if you do that, you risk of destabilizing somebody's illness because you don't know how they're going to do in that transition or on that new medication. You can more than likely precipitate withdrawal by trying to do that switch. And now you have two exposures to medications where in pregnancy, where we literally like to keep that to as few as possible. And again, we don't know if that's actually going to produce a better outcome for that newborn. So again, when we're choosing medications for mom, we're going to choose the one that is best for her and her illness. And then we're going to weigh those risks of that drug against the risks of the untreated illness. And for this area, what we're talking about is risk of relapse, and that increases the risk of intoxication and withdrawal, for infectious disease, high-risk behaviors, overdose death, etc. And all those same things that I talked about with risk of the medications are the same with the risk with not being on these medications, such as preterm birth, low birth weight, maternal complications, and NAS. And then we also risk having maternal and newborn separation at the time of delivery or after if mom is in a place to not be able to take care of the baby. So this is just some work. There was a time where people were really wanting to withdraw women from these medications, such as methadone or buprenorphine, during pregnancy. And what a lot of our work shows is that risk of relapse is not very clear. So we don't have the precision to tell an individual what's your risk of relapse, but for most, it's very, very high. And so it's the medication-assisted withdrawal, which is the MAT here, is not something that we do in pregnancy. So this was the tool I was talking about. As clinicians, Dr. Smith can attest to, and other folks on the call, we sit down and have these risk conversations every day. And if you're having this conversation multiple times every single day, it's sometimes helpful to have these tools to be able to guide that conversation, to hand to the patient that they can actually review as well. So all that information I just gave you is part of a shared decision-making tool, and we should actually update some of the risk estimates based on the newer data, but that's available for folks that want it. Every patient that you're seeing with opioid use disorder should be given access to Narcan, and there's a few ways to do that. It can be prescribed. It's actually over the counter. It's about $45 per prescription. And it's also free at community distribution centers. If you Google Narcan Community Distribution Center, you would be able to have your patient go pick that up there for free. So we want to do a lot of education around Narcan for our patients, that they know how to use it, that family members know how to use it, people that they're using with maybe know how to use it. There's other harm reduction strategies we can also recommend, which is don't use alone. Really think about the situation you're putting yourself in and any risk that can occur, and modify your behavior so that you're not taking as much risk when you're using. We can talk to patients about contraception. These other things, fentanyl test strips, they sort of just, they're basically yes or no. So you don't know how much fentanyl is in your drug. So they're not all of that useful, but nonetheless, if it could be somewhat helpful for folks. We don't have syringe exchange programs or safe injection sites in South Carolina, but it's something that we should have. Just to, as a heads up to everybody, I'm sure people have heard of this, xylazine. It's sort of being cut into a lot of drugs, but in particular into opioids. This is actually a tranquilizer, and people can have really significant blackouts with this medication, with this this drug, if it's cut into whatever it is that they're using. And it's sort of having pretty significant effects in a lot of ways. And I'm going to, for the sake of time, just sort of go past that if people want to talk about it. But just to summarize, when you are treating opioid use disorder in pregnant and postpartum women and you're using medications, you really want to make sure you're having that risk-benefit discussion with people, so people feel that they have the information they need to make an informed treatment choice, and that they're educated about that, because you will see a lot of places where they'll get pushback on taking these medications, even from with friends, family, partners who are maybe well-intentioned. Within the addictions field, there are people that will, in recovery circles, tell people you can't be on these medications. You'll hear this from health professionals. So really important that we are doing a lot of education about these medications. We want to use shared decision-making as much as possible, prioritize treatment choices that's best for the woman's health, and don't switch medications in pregnancy. That's our Mom's Impact and Echo. There's actually, if you ever wanted to do anything, again, I put Mom's Impact here because if you have a patient with opioid use disorder, just call us. We're happy to help in any way, walk you through next steps, get that person started on treatment, etc. If you want to learn more about treatment of opioid use disorder, there's another Echo, which is really fantastic, that can support that effort. So I'm going to go ahead and